Good evening, everyone. My name is Melvin McInnes, and I'm the director of the Heinz C. Prechter Bipolar Research Program. Welcome to the 15th Annual Prechter Lecture. This is an annual event, and it's part of the Prechter Bipolar Research Program's commitment to sharing our work and educating the public about bipolar disorder. It is also to honor the memory of Heinz Prechter. With tonight's program, we will be building a public discussion on the reform needed around mental illness in the United States. I want to start with some housekeeping for the first instance. Firstly, I want to encourage everyone to use the Q&A function for questions rather than the chat box. The captions can be turned on on your Zoom in the lower left corner there. There's a little button that says CC and enable live transcript. Also, if you're a social worker who's registering to get continuing education credits for this lecture, you'll be emailed a survey tomorrow. You fill out the survey and receive your certification. So a brief overview of the Prechter program. Bipolar disorder is a complex disease that affects millions of Americans and more than 40 million people worldwide. The Prechter program is investigating bipolar disorder from a number of angles. Firstly, we have our flagship program, the longitudinal study, which engages individuals over their lifetime to learn what causes people to become ill, what keeps them well, and just to study the disease in general. We have two primary thrusts of our work. We're looking to identify the mechanisms of the disorder, and with that, we're looking at the genetics, we're looking at the cellular level, looking for mechanisms and things that cause the disorder. And equally importantly, we're looking for ways to predict the illness, to see how we can figure out how people are progressing all through their lifetime. What features can we identify that could help us anticipate when problems are coming up and how we can cut them off at the corner. Our work, we have several collaborations. We work with a number of different schools here across the University of Michigan. We have a number of international collaborations. And in total, we have approximately 36 active projects that are going on throughout both the University of Michigan, nationally and even internationally. So for this evening, a little bit of a summary of what's going to happen. So firstly, I'll introduce Paulie Prechter, and she will introduce our guest lecturer. Our featured speaker will talk, and then we'll have a panel discussion and a Q&A about health reform. We have a very dynamic panel that's going to be speaking tonight and are talking and interacting and talking about the issues that Norm Ornstein brings up. But first, I want to introduce Paulie Prechter. Paulie is passionate in helping and supporting her community, and Paulie's community includes Michigan, includes the United States, and in fact, it really includes the world from my perspective. Paulie is the founder of the Heinz C. Prechter Bipolar Research Program, and we share a common vision of a world wherein individuals with bipolar disorder are going to be able to, or are leading a fulfilled, passionate, productive, and happy life, throughout their existence and lifetime. So with that, I want to introduce Paulie, who's going to introduce Norm.
Good evening, everyone. Thank you, Melvin. It has been over 20 years since Heinz passed away. His legacy, one of light and innovation, continues to impact and inspire. I know he would be so proud of all that has been accomplished in his name, and I also know that he would want us to continue pushing the limits, to be fearless, to think outside the box, to tackle this illness from all directions. During Heinz's lifetime, it was nearly impossible to talk about his illness. Since then, we've come a long way in terms of better understanding bipolar in the ways we treat it and manage it, but so much more needs to be done. Today, at the 15th Annual Prechter Lecture, it is my great honor to introduce our speaker, Norman J. Ornstein. He's an accomplished political scientist and a senior fellow emeritus at the American Enterprise Institute, where he has been studying politics, elections, and the US Congress for more than 4 decades. He's an author and frequent contributor to the Atlantic and the National Journal. Foreign Policy named him one of its top 100 outstanding global thinkers. He has a personal connection to bipolar illness and the problems people face who have mental illness with several public systems, including the mental health care system. Norm, his wife Judy, and son Danny established the Matthew Harris Ornstein Memorial Foundation in memory of his late son. One of their projects was the production of a documentary entitled Definition of Insanity. It is the story of Miami-Dade County Circuit Court Judge Steve Leipman's tireless efforts over the past 2 decades to decriminalize treatment of those suffering from mental illness. Norm is an alumnus of the University of Michigan. Ladies and gentlemen, it's my distinct honor and privilege to introduce to you Norman J. Ornstein.
Wally, thank you so much. And I want to thank the entire Prechter family. Thank you, Melvin, and the Prechter program on bipolar research for all that you have done and are doing. And it is a great honor to be giving this lecture. And not only did I get my PhD from the University of Michigan, my wife and her sister and her mother all have BA degrees. Her mother, who went in the 1940s as a math major, quit after her junior year because the war ended, but came back in her 80s to get her degree. And my late son, Matthew, spent 2 wonderful summers at the debate camp living in East Quad. So our ties to Ann Arbor are very, very strong. And I'm just sorry I can't be there in person now because of what COVID has done. So I'm not your typical Prechter lecturer. I'm not a mental health professional. I'm not a researcher in this area. You could say with the many decades that I've been studying Congress and the American political system that I have a PhD in pathology, but it's a very different type than what we're going to be talking about. I want to elaborate a little bit more on my story and why I am here as somebody who wouldn't be the typical lecturer. And as Wally said, it is because of our own personal tragic experiences. My son, Matthew, my son with my wife, Judy, was a brilliant young man who had enormous accomplishments. He was witty and funny, did stand-up comedy. He was a national champion high school debater, thanks in part to his training at the University of Michigan. He went on to success at Princeton and then to Hollywood, where he was doing quite well when at age 24, he had a psychotic break, reasons still unknown, and then spent 10 years with a horrible, arduous journey that ended ultimately in his accidental death in a hotel room in Delaware, carbon monoxide poisoning. But he and his family and all of us went through the kind of horrible experiences that are shared by so many in this society. Matthew believed that God had come and taken his soul, but for reasons unknown, had done so while leaving his body behind. And his was a journey to try to recapture his soul. He had no awareness or insight into the fact that he had a serious mental illness, a phenomenon known as anosognosia, which we know now and can pinpoint in the brain is something that affects a very substantial portion of those who have a serious mental illness. He believed that taking medication for whatever reason would alter his path and make it more difficult for him to make amends with God. He became quite religious, but it was an extraordinarily painful and difficult life for him. And through it all, we encountered all of the problems that exist in a broken system of mental health care, along with a broken system in the criminal justice system, although that was not the source of Matthew's great problems. I want to make one more point before I go on to talk more about the nature of that system. And what we saw was roadblocks at every turn. But one of the things that was most maddening was that so many of our friends, highly educated and presumed knowledgeable people along this path who would give us advice would say things like, why don't you just kick him in the ass? A belief that there was something willful about what he was doing. And this sense, and part of it is because we use the term mental illness instead of brain disease. instead of viewing it as a disease of an organ, no different in terms of what can be done to the human being than cancer or heart disease, has created the stigma, or at least added enormously to the stigma that has made all of this so much more difficult. But we also encountered the problems with the healthcare system and the legal system that made it impossible for somebody who has anosognosia, who is over 18, who is viewed as an autonomous individual capable of making his or her own decisions, when in fact, in so many instances, just like with my son, that lack of insight means that they're not making decisions based on their own self-interest. And there's no role in this system for parents or family or even professionals to be able to do anything to help. Now, I would also note that along the way, as we, people of means, did everything we could and consulted with a wide range of psychiatrists and other professionals, no one told us, for example, about the existence of the National Alliance on Mental Illness, NAMI, or its family-to-family program, where we might have been able to interact with others and learn perhaps from their own difficult experiences. At the same time, what we have seen, with means or not, that there are simply no options for treatment, even if an individual is deeply psychotic and unable to assess his or her own conditions. The standard that we use for putting somebody into a facility where they can be analyzed and treated against their will is, in most instances, quote, an imminent threat to oneself or others, which literally means a gun to your own head or a knife to somebody else's throat. And even then, if you find the ability to hospitalize somebody, it's usually for 72 hours, and then they're out on the streets. And of course, what we have seen in many instances is that people are thrown back onto the streets, even if they are floridly psychotic, because the institutions don't want to keep people under these conditions, and especially if they're not going to be paid directly for it. What we also learned is there are nowhere near enough professionals trained to deal with serious mental illness, from diagnosing the conditions. And with our son, Matthew, we never got a firm diagnosis. We had some professionals who thought he was bipolar, others who said it might be schizoid affective disorder or schizophrenia. I'm not sure that it would have mattered. Certainly it wouldn't have mattered when he resisted any kind of treatment and we had no option to be able to provide it. But it also tells you something about the state of care in the society. And frankly, we found that the people that we talked to, even in many instances, didn't have the capability not only of diagnosing the condition, but of trying to understand what balance there might be between medications and therapy, much less understanding the legal system. We lived in Maryland for most of the time that Matthew was ill, which is one of the worst states to try and find any kind of treatment. And its legal system, including judgments that have been made by the highest court about what you can do to try and bring medication or treatment to somebody who's resisting it, were unknown to any of the sophisticated professional psychiatrists whom we encountered. And of course, there's also simply too many who are unwilling to treat anybody who has a serious mental illness. The blunt reality is a very large share of psychiatrists want patients who come in on time, sit for 45 or 50 minutes, and give their complaints about their spouses or their jobs or their children or their relationships, and then leave and have the insurance that get paid. My son, even if he had been willing to see somebody at different points along the way, could not have in any fashion made an appointment at precisely 11 on a Wednesday. And when you have most people who don't have the ability to pay, and you don't have insurance companies willing to do it, and even if you do, under the so-called parity that we have in our system, the fact is that you have insurance companies who say, yes, we will pay for you to see a psychiatrist. There is one in your area. which might be 100 miles. And maybe you can get an appointment in the next 3 months or 6 months. And I can tell you stories, as many of you no doubt have, horror stories of people who had a relative in crisis who needed to be able to get some treatment, who were told, come back in a few months. The analogy that my wife has used is if you go to the fire company and say, my cat is up a tree, we'll be there in 10 minutes. If you say, my house is on fire, it will be, well, I'll tell you what, bring your house by next Thursday at 4 o'clock. That's when we can see it. And while that may be an imperfect analogy, it's a pretty powerful one for the state of treatment of those with serious mental illness in the society. We need to do a lot more to get people, nurse practitioners, as well as psychologists and psychiatrists, who are willing to treat those with serious mental illness and who have the ability and the training up and down, including the legal system. And again, my wife has an idea, Judy Harris, to be able to find incentives so that we can have a subspecialty in psychiatry that might include financial incentives, because let's face it, another part of the reason is that you can go through extraordinary lengthy training. This is something that we see with geriatric psychiatrists as well, another part of the element of brain diseases that we have, and then find that the only payment that people can provide is on Medicare, and it is simply not adequate, especially when you can't get the kinds of payments for tests and other things that enable physicians, primary physicians at least, to be able to do a little bit better under these programs. The same with Medicaid. I will say as an aside that as Congress and the White House are going through this torturous set of negotiations over the Build Back Better program, that may or may not include Medicare being able to provide for things like dental care and eye care, that it's a damn shame that it doesn't include care for serious mental illness as well under Medicare. Now, along with that, of course, we know many other ailments within the system. There are not enough beds anywhere near to handle those in crisis. We have had a reduction of about 90% of the beds that existed at one point in time. Of course, much of that back during the days when we had these horrific asylums. Things have been changed, and we've seen that deinstitutionalization, but it has not been accompanied by an adequate number of beds, and a lot of that is a consequence of Ronald Reagan basically cutting the pins out from under federal support for community health centers, and as well as that, the IMD exclusion, as it's called under Medicaid, where you cannot get Medicaid support if you have a facility dealing with issues like mental illness or substance abuse with more than 16 beds. And I'll give kudos to Debbie Stabenow, who's been very, very strong on these issues, and along with Republican Roy Blunt, has found a little bit of a workaround in this area, but it's nowhere near enough. We need more beds, and we find over and over again stories, tragic stories of people, even if they're picked up by police or with families who are willing to find a place to put them, that there is no place to go. And of course, the repositories now have become the jails and prisons. And I'm sure this is an audience that I don't need to tell that the three largest facilities treating those with mental illness in the country are the LA County Jail, the Cook County Jail, and Rikers Island in New York. And Rikers Island is being phased out, and God knows what will happen in the state of New York when that occurs. Now, along with that, what we have seen as my family faced this tragedy, just as the Prechter family did, except on a much smaller scale. But as Wally said, we looked for ways in which we could deal with our tragedy and the horrific, horrible pain that we felt. And we tried, in the words of Joe Biden, to turn grief to purpose, and created our foundation. And we have now spent several years. Our son died at age 34 on January 3rd, 2015. And we've been trying to learn as much as we can about the nature of this system and about research on the brain. The research priorities of the country are extraordinarily badly skewed. The Treatment Advocacy Center, which is a premier organization for dealing with these issues of serious mental illness, did a recent study, reported that fewer than 10% of the related NIMH grants for bipolar disorder are likely within 20 years to help anybody who currently has bipolar disorder. The priorities at the National Institutes of Mental Health and its affiliate, SAMHSA, have not focused on serious mental illness or on ways to deal with the problems now. They're looking at research that may have great payoffs a long time down the road, and it's important and very good that we're getting much of that research, but we need a focus on what can be done to help people now. And that's where institutions like the Prechter program and the Brain and Behavioral Research Foundation, another excellent one, becomes so important. There is so much that can be done in the private sector. But if what we find is that federal grants aren't going in the right places, then young researchers are going to turn to do other things. And so we've got to find better ways. And I'm hopeful that we may see some change, but I don't see it very much on the horizon. Now, at the same time, there are few people outside of the medical profession who are trained to deal with or talk to people with serious mental illness, whether it's school personnel, including teachers and principals, much less the safety officers, police or judges or wardens or prison guards, and more. One of the other programs that we have done, which we're very proud, is to work hand in hand with a remarkable psychologist named Javier Amador, who wrote a book called I'm Not Sick, I Don't Need Help, and has created a nonprofit which flows from the tragedy he had with his own brother, the Henry Amador Center on Anosognosia, in which he has learned how to communicate better with people who have no insight into their illnesses, where logic doesn't work if you're trying to talk to them. We found that over and over again with our own son. And imagine if you have somebody with serious mental illness and anosognosia who's also a national champion debater. You don't get very far. But Amador has found a better way in which you can learn and listen and empathize and find ways to agree and partner that don't acknowledge that you think this person doesn't know what he or she is talking about, and has trained people in this technique, family members, first responders, and others, and is training trainers and doing programs around the country. And we've worked closely with him on this front, and it's much needed. All of you, I'm sure, have seen some of these terribly disturbing videos on Twitter or in other places in schools where a child is acting out a little bit, and a safety officer or a policeman will come in and slam them against the wall or put them in handcuffs, 5, 6, 7, 8-year-old kids, and take them out. And it's devastating to them and a trauma that will likely make their lives much, much worse. And if we can get people more sensitive to when somebody is behaving in a particular way because of their brain disease and deal with them at a different level, it will be good for everybody. And that's a top priority that we have to deal with. And obviously another part of that is the crisis intervention training that is being done in many places around the country. And I'm going to talk a little bit more about our movie and Judge Steve Leipman, the remarkable man, when I turn a little bit more to what we can do. I do want to mention that if anybody is interested, and I hope you will be, you can watch this film, a documentary that aired in public television, at www.doifilm.com. DOI for definition of insanity. No cost, and you will be blown away by what he's been able to do. Now, along the way, the reason we did this movie, as we were trying to learn before we acted, we encountered Judge Leipman first at a session that Patrick Kennedy's Kennedy Forum did up in Boston early in our tenure. We got to know him. We went down to Miami and saw his program, and were just completely blown away by what he had done. Judge Leipman, who is a county judge in Miami-Dade, which is the 7th most populous county in America, with the largest concentration of people with serious mental illness, has completely transformed the way the criminal justice system down there deals with people with serious mental illness, and has found ways to save lives and save money. And I'm very happy to say that much of what Leipman has done has resonated in different parts of Michigan, in Detroit, and now to some degree in Washington County as well. And we're trying to spread best practices around the country. Because the fact is that while Matthew had very few encounters with the criminal justice system, he was the exception, not the rule, for those who have a serious mental illness. There are regular encounters between the police and those who have serious mental illness, called sometimes when a crisis happens by family members who can't cope anymore, sometimes when a neighbor or passerby calls the police because they see somebody exhibiting strange behavior. And every day we see a story of a tragedy, of police who come and they're trained to escalate conflict if somebody doesn't obey commands. The worst thing you can do for somebody who has a serious mental illness, they respond badly, and you often end up with tragedy, death, tasing, arrests that are unnecessary for resisting arrest. People end up in jail. Often they are put in solitary confinement, the worst thing you can do. They are dealt with by poorly trained and poorly paid prison guards who often mistreat them, sometimes because they don't understand, sometimes because they're just not the right kind of people. And then they may be thrown back out onto the street in even worse condition. So we know as well that a very large share of those with serious mental illness, especially those who have anosognosia and do not accept or will not take other treatment, they self-medicate. And the number of those with dual diagnosis, a substance abuse disorder as well as a serious mental illness, is extraordinarily high. And of course, a large share of those who are in jails or prisons who have a serious mental illness or any kind of mental illness are there because of drug charges and because of the draconian sentences that we have had for the last 30 years, only now just beginning to be slightly ameliorated for those drug charges, including very minor ones. And that jail or prison is absolutely catastrophic for those who have a mental illness. The reality is that 70% of those who are jailed have at least one mental illness diagnosis or substance use disorder, and up to 1/3 of all of those in jail have a serious mental illness. We also know that we imprison more people than any other country in the world. We have 4% of the world's population, 25% of those who are in jails and prisons. And since 1980, the number of those in jail has grown by 500% with longer sentences. And of course, for all the reasons that I've suggested. And we know that people who have a mental illness are 10 times more likely to be incarcerated than hospitalized. And we know as well that even when police who pick up somebody with a mental illness, who know that the person should get treatment and be hospitalized, find either that there is no place to take them except the jail, or that if they go to the emergency room, they'll have to wait for hours filling out paperwork and taking them off the beat. And so it's easier to take them to jail. We need to streamline and change this system. And of course, the reality is that not only do the people who have a serious mental illness pay a terrible price for this, not only do their families have to go through incalculable pain, but taxpayers pay a ridiculously heavy price. For example, wrongful death and assault suits are costing tens of millions of dollars every year because of the way in which police deal with these issues. And in Miami-Dade, where they finally managed to cut the number of deaths dramatically and cut the number of arrests in half, the city of Miami was able to improve its bond rating just because of that, saving taxpayers even more money. And these are costs that most people don't even know exists. And it's a great drain on the society. Now, not only that, the costs of the way in which we handle treatment are absurd. Here's another example from Miami-Dade. The county pays $100,000 a year for each person with mental illness in jail. But Florida pays only $1,400 a person to treat those with mental illness to maintain stable lives and stay out of jail. And then there are plenty of others who get no treatment at all. If we switched our priorities, it would save enormous sums of money while also enabling people to recapture their lives, which, as Melvin said, is a central goal of what you're doing with the Prechter program. So what to do? First, we need a model crisis response system that brings coordination to all the different elements in this process. And that includes many of the things that we're starting to do now. There may be a little help that will come as we expand this 988 number so that it's a clear understanding of who has a mental illness, as we see many jurisdictions now trying to move a little bit so that you get mental health professionals going out when there's a crisis call for somebody involving a mental illness instead of police who are ill-trained to do it. And even some of those who've had crisis intervention training forget it when they get to the point of an encounter. And here, as an aside, one of the things that Judge Leipman has done and that we see in our program, in our documentary, is because so many police have their own mental health issues. More cops die of suicide every year than die in the line of duty. PTSD is rampant, and that contributes to the misunderstandings and the violence that can occur out there. And crisis response has to include the police as well. We should be applying a population health model to the criminal justice system, not a criminal justice system to the mental health and substance abuse system. We need care that focuses on prevention, assessment, diagnosis, case management, medical management, the way in which we deal with other illnesses and other diseases. What Judge Leipman has done, I'll just say very briefly before I conclude, is first, he's created a pretrial diversion program for misdemeanors and nonviolent felonies, which includes so many of these drug-related charges, so that before anybody goes to trial, if they have been diagnosed with any kind of mental illness, they're given a choice of going into a program that provides wraparound services, a key to all of this. You can't just have a treatment where somebody comes once a week and says, take your meds. You've got to have a social worker, a medical professional, and a peer counselor, and housing, a critical part of this. If there's no housing, all of the rest of it falls apart. And he's got people who then are evaluated over the course of a year. And if they comply with the program, and the vast majority do, they don't want to go to jail, even if they are psychotic, they know what that means, then they have their charges expunged and they're able to go out and lead productive lives. He's trained over 7,600 police officers in a comprehensive program of crisis intervention training over a week, and then follow-up, which occurs. And because it also includes treatment for the police who come to understand that they have their own issues, and it's done outside the system, not where there's a stigma or penalties that come from inside the system. They've changed the whole culture of policing. We're at a critical moment, and at a moment, I think, where we can finally get some serious action out there. People beginning to understand what the nature of brain diseases are, and that we have to deal with this set of issues. Understanding the perfect storm of the need to do criminal justice reform and police reform and mental illness system reform, and that they can all work together and work in a synergistic fashion to make for a better and more humane society. My family does not want others to go through the pain that we went through. We do not want other people who have a brain disease to have to go through the hell that our wonderful son, who did nothing to deserve what he got, had to go through. And I hope that we can work with the Prechter Center and others to make this a better and more humane society that will work to the benefit of all of us, whether you have a mental illness or your family is involved, or if you're just somebody residing in the country and paying taxes. Thank you very much.
Thank you very much, Norm, for sharing your story and for beginning the discussion on the challenges that we face in our society with all of the difficulties and challenges that are out there. I want to start now by introducing the panel, and I'm going to ask that the panel members go on camera. And what I'm going to do is just to call out the panel members to introduce themselves and to share with us a little bit about their involvement in mental health and the things that they do and that. So I'll start with you, Julia, and to let you take the talking stick. Tell us a little bit about yourself and your work.
Sure, thanks so much. I'm Julia Kyle. I am the Director of Behavioral Health Strategy for Blue Cross and Blue Shield of Michigan. I'm a clinical social worker by training and have spent the majority of my career in and around the public system, working with people with serious illness. I would say one of my greatest passions in coming to Blue Cross of Michigan is actually bringing the care that's available in some places like the public system into the commercial and Medicare space. So historically, there's a lot of great services that are available. If you have Medicaid and community mental health, there's a lot of more ranges of care. But in the commercial world, if you're sick, you're either, historically, I mean, it's a little bit better now, but you're inpatient or you're outpatient, and we're waiting for people to get really sick, and it's just not good care. So thanks so much for having me. This is one of my favorite topics to discuss, and I think there should be some great conversation.
Thank you very much. Amy Kilbourne.
Yes, hi, I'm Amy Kilbourne. I'm a professor at the University of Michigan, and I come from a background in public health. So a lot of things that Dr. Ornstein talked about really resonated with my passion of finding ways in which we can get evidence-based practices off the academic shelf and into the hands of the consumers and providers who care for them. And so the work I've focused on has been for the past 20 years on developing strategies to get more frontline providers implementing best practices using quality improvement methods. And what really is drives my passion in this field in particular is that most of our great ideas come from community-based members and organizations and frontline providers, many of whom are the nurses and social workers at the front line caring for these individuals. Personally, I have a connection to that in part because I had a family member who's hospitalized, and one of the best people who actually helped her was a nurse in LA County Hospital at the time. And I think, since then I've gotten some great mentoring from psychiatrists and psychologists and social workers and nurses in my training, and hopefully we'll put it to good use to help other providers and empower them to use best practices in routine care.
Thank you very much. Brad.
Thank you. Hi, I'm Brad. I'm an assistant professor of management in Hong Kong. The reason I'm here is that while I was finishing my PhD in behavioral economics at Wharton, I started to demonstrate some slightly unusual behavior. So for example, I started to run 20 miles a day while sleeping about 3 hours per night. And then things started to get particularly odd when I started to think that there were secret messages being sent for me on social media, think that people were listening in on my phone calls, and at times even thought people could read my thoughts. So if it wasn't clear from the fact that my name's just listed as Brad, I'm a patient and also a research participant. But what really, I consider myself really lucky to have experienced is that after my PhD, I ended up doing my postdoc at Michigan, where I ended up being connected to the Prechter Center. And thanks to them, and the amazing care I've received there, the people there are phenomenal. They're extremely competent, and they also treat you with such empathy. It's actually the first time where I've been given Press Ganey scores to fill out. I've been excited to fill them out with positive evaluations. But thanks to them, I actually started to feel and control my brain for the first time in over 10 years, and I continue to do so. So it really is, the care they give is fantastic. And then the other great part about the center is participating in the research. It's enabled me to feel like I'm part of the community. It's also makes you feel like you're contributing to knowledge which could benefit other people as well as yourself down the line. And also, as a researcher, I just think the things that they're doing are super cool. And at times, I'm a little envious of the things that they're researching. So if anyone has any questions for me about my experience living with bipolar or as a research participant, just let me know.
Thank you, Brad. Paulie Gibson.
Good evening, everyone. My name is Paulie Gibson. Before I introduce myself, I just want to thank Dr. Ornstein as well as the Prechter family, because, clearly, as they've stated, what they are doing for society and the ways that they're contributing, unfortunately, will not benefit their loved ones. But they are doing so much to help so many. So I just wanted to acknowledge that. I'm a clinical associate professor in the Department of Psychiatry. I'm a clinical psychologist by training. I direct our trauma and grief clinic that's in child ambulatory psychiatry. And I've also been engaged in community-based research for the past 20 years. Presently, I'm very engaged in a trauma-informed school project. And as was so eloquently stated by Dr. Ornstein, there is a school to prison pipeline. And I'm hopeful that the work that we're doing around trauma-informed schools will help to disrupt that. Additionally, I'm engaged in research that's focused on adolescents and young adults around suicide prevention. I'm delighted to be here. Thank you.
Thank you very much, Paulie. Mary Ann.
Thank you, Melvin. It's quite an honor to be here with this really incredible panel. I have had a very long and varied career in connections to this particular issue, including starting early on as one of the founding members of the advisory board for the Depression Center at the University of Michigan, thanks to John Graydon. And at that time, was because of my work at Blue Cross and Blue Shield of Michigan, way before Julie was there, where I was really working to get parity in mental health benefits at that point. I've had a career in the public sector, in the Department of Human Services, working with Milt Mack, who I know is one of our attendees here, trying to really improve the mental health system in our state. And today I serve on the Washtenaw County board, the Community Mental Health Board. And I'm so glad that Norm, you called us out in your remarks for some of the real advancements that we're making in the county. And I hope through the course of the discussion tonight, I can share some of the positive things that are happening to increase access to care. And then last but not least, I too have a personal connection to this, to the issue of bipolar disorder. My first husband died effectively from bipolar disorder in 2005. It was a very long journey with him as well, and very similar to what Norm and Wally and others have experienced. So I feel this issue both personally and professionally, and I'm just honored to be here.
Thank you very much. Thank you, everyone, for your for introducing yourselves and talking about your work. There are many different things that have come up in the chat or the Q&A here. But I think that one of the sort of salient features, Norm, that had kind of sailed through in your talk was the issue of culture, how we're able to address culture. We've got many roadblocks that have been put up, and many difficulties that come up both in the context of the prison system and the reactions or the interactions between the judicial system and medicine. So in order for us to really kind of get the ball rolling, how are we going to address the issue of culture? There's been questions here about how do we change policies in places like in Austin and around the country. There are questions about what are examples of states or communities or countries where they've been successful at changing the culture of healthcare for mental health. And so a big topic, but let's take it on. How do we change and adapt culture?
Let me offer a few observations here. I'll return to Miami. When Judge Leipman has been doing this for about 20 years, did a deep data dive. He found that there were 97 people in this huge county who had cost the county almost $15 million over 5 years, who were chronically homeless, primarily schizophrenic or suffering from bipolar disorder. who were cycling in and out of jails and out of their system. And, they'd be picked up on the streets for vagrancy, thrown into jail, put in solitary confinement probably for a month, and then just dumped back out onto the street. And they go through this cycle. What he's now been able to do is to get a change in Florida law where they have an assisted outpatient treatment program in Florida. 47 states do, Michigan does as well. You do it through the civil court system, and there should be in our safeguards, but it doesn't help if you have people who are cycling in and out of jail and who don't have family members who can intervene or even bring it to a court. So they're now working this through his criminal court. And what they found is they're able to get many of these people who are chronically homeless, now get them some treatment, including a long-term injectable, and it's having a tremendous impact. We have to find a different way to deal with those who cannot help themselves, who, while protecting civil liberties, and there are ways of doing that. More broadly, let me say, Melvin, that one of the things that I've experienced, my family's experienced, and I'm sure many others have, since I've been more public about this, is we get flooded with people getting in touch with us, emails, phone calls, and otherwise saying, I've never told anybody this, but, and it's about themselves or a family member, or perhaps one of their family members who died by suicide, or others, and they don't know what to do. They say, my son is like yours, what do I do? And they haven't talked to anybody because we do have this level of stigma. And it's a level of stigma because we don't think of this as a disease of an organ. And at the same time, our prison and jail system is an international embarrassment and catastrophe. There is nothing that focuses on rehabilitation or on helping people to regain their lives. It's all about punishment. And we throw people then back out onto the streets. We've got to change that. In Sweden, in Norway, they have a completely different model, and they don't have the level of problem that we have. We incarcerate far too many people. And of course, there's a race element here that we cannot ignore. And that includes the reality. We always worried that if police encountered our son, it would end tragically. It's bad if you have a serious mental illness. If you're a person of color with a serious mental illness and you encounter the police, your chances of a tragic outcome go up enormously. There are so many areas or levels in which we have to deal with this. But I think primarily we have to start thinking about this in a different way. And finally, let me say, I look at all these other diseases that have a huge lobby that hits Congress, and appropriately so. Alzheimer's now is getting an enormous amount of attention. We've seen it with breast cancer. We see it with prostate cancer. We see it with things that have many fewer people. There isn't a family in America who hasn't been touched by mental illness, but we don't organize in a fashion that gets the kind of action in Congress that we need. And whenever we've had it, like with parity, which is a pretty poor construct for the reality of it, it's because there were members of Congress themselves touched by serious mental illness.
Thank you, Norm. I'm interested to hear from our Michigan folks in the policy arena here. Amy, do you want to start the commentary here?
Sure. I think that these are really, really important things to think about. And one of the areas where I think Michigan can really make a difference in these other spots that you've talked about is that there's a movement now in Congress and in government around evidence-based policy. Well, it's really been around for a long time, but it's really taken up speed. And I think the other job I have is I work at the VA, and it has embraced this concept of paying for programs and policies that show evidence. And in doing so, just ensuring that people get the right treatment at the right time. And the policies are also supported with empowering frontline providers to be able to deliver those treatments. And I think that's one of the first things to do. The second thing is I think we need to really, embrace the different diversity of types of providers who care for these individuals. And so in particular, it's not just the psychiatrist, but it's really a team of individuals who care for these patients and these consumers. And
Right.
there's been 20 plus years on the chronic care model research that has shown, and that's a model that I think could really help with improving the lives of these individuals.
Right. Thank you very much, Amy. One of the things that was brought up in Norm's discussion was the incentives. And so, Julia, speaking on behalf of someone that is in that domain, how successful are we at incentivizing not just providers to be really available to provide care, but also there's an incentive there for individuals to seek care and to get care. And so share with us the experience here in Michigan as in the context of incentivizing care for people with mental illness.
Yeah, so right now, I mean, I think that's really challenging. So historically, I mean, unlike any other, you think of any other type of care provider in our system, behavioral health providers do not have to take insurance. Okay, so if you think of it, there's not a cardiologist out there that doesn't take insurance, or an oncologist that doesn't take insurance. Behavioral health providers don't have to. They have long wait lists. There's not enough of them out there. They can take private pay, which really cuts down on access for all of our patients. So trying to incentivize people to take folks, and then trying to actually create some more value-based payment structures that we pay people for the services that are provided. So one way in terms of changing per diem payments to a more of a value-based kind of DRG type model. So what I mean by that is instead of everybody gets kind of the same payment, if you're taking more challenging cases, if there's people that require extra support in hospital or other places, being able to pay those folks more so that they aren't incentivized to take very mild cases, opposed to somebody that is maybe psychotic or maybe requires a one-on-one, which is more costly for the health systems. So trying to use more of a kind of a value-based, outcome-based, and pay people appropriately, I think is the direction that we're going to have to go.
All right, thank you very much. I think, Marianne, that really falls into your domain there about, how do we, organize larger systems to have a concerted effort to provide care across the board.
Yeah, well, a couple of things. First of all, as Norm noted in his remarks, we have underfunded and underpaid practitioners who deliver mental health services historically in our country. We pay cardiologists much more than we pay psychiatrists or psychologists or social workers, much more. And we have, really distorted values when it comes to what we pay for in our healthcare system. So that all needs to change. And, again, I want to say something hopeful and exciting, and Norm also raised this. Our Senator Stabenow, really has fought for this new approach to health homes, community-based care health homes. And Michigan is now participating in that health home model, which is providing significantly more funding and a more coordinated set of services for people with behavioral health needs. And it's going to be across our state. Washtenaw is one of the areas that's been doing this for quite a while, but this is expanding across the state. It is a great opportunity to significantly increase access to care and to better recognize that we need more money in the system to provide better access.
Thank you, Marianne. So the key words that I took from that is coordinated care, and Paulie, your interests span a number of different kind of entities, including, as you talked about, PTSD and a wide range of comorbid features with bipolar disorder, and I think that comorbidity, and which means just co-occurrence of other illnesses with bipolar, is really what happens. I mean, individuals with bipolar have a lot of substance abuse, they have PTSD, they have all sorts of other things going on at the same time. How are we going to coordinate this and bring together communities, both of providers and of services, to really get a unified system going here for the people that we serve?
Yes, thank you for that question. I think, the way it was illuminated in Dr. Ornstein's talk is exactly right, in terms of everyone has a role to play, and we need training, we need access, we need solutions, and all of these different systems. So for instance, in the school system that we're working in right now, similar to what Dr. Ornstein was talking about, he spoke about a lot of the police officers themselves having PTSD. And so oftentimes when they're interfacing with people who are severely mentally ill, they may be having their own trauma reminders. They may be activated in some way, and that contributes. And obviously they're trained. We have to acknowledge the way they're trained as well. So similar to that, what we have learned in the work that we're doing in the school system is that the staff and the teachers are also traumatized. And so we've been working with them to build up, we're doing programs called Compassion Resilience Circles. And so we're working with them to enhance their capacity around helping them to understand their burnout, their fatigue, their trauma reminders, and providing that support so that when they work with children who are traumatized and are activated by what's happening in the school system, we're hoping for a better response instead of expulsion, instead of suspension. And as we talked about, we can't ignore the race element. So my point here is just to say that we need solutions in all of these different systems, because unfortunately the mental health system, as we said, there's access challenges and everyone can't be treated in that system. And we also have to involve communities. I loved how Dr. Kilbourne talked about how a lot of the innovative solutions come from people with lived experience. It comes from communities. So we have to make sure that there is
We lost Paulie there for a moment. She froze. We'll let her wait for her to get her internet connection back. But there was one of the points that Paulie made, Brad, that I wanted to get your perspective on. Sorry, Paulie, we lost you for a moment there on your internet connection. But Paulie mentioned community, Brad, and also touched on, Norm touched on how we're going to get out, individuals outside the health system and outside the systems into the, into the discussion. So you have a very unique set of experiences in going through a number of different educational systems and seeing the challenges at ever so many levels, both from the perspective of a student and now as a faculty member and a person, with real lived experience. So what are your comments on and how to engage community and how to engage the educational systems at all levels?
Yeah, so I think one of the major hurdles to, engaging the community from my own experience is that people don't have enough exposure to discussing it. As soon as you bring it up, they look terrified and aren't really scared. And I don't think it's necessarily from a bad place. I think even people who are well-intentioned who would like to help you or discuss the condition, they just don't. Since it's not talked about, they don't really know the proper framework to actually discuss it. What's an appropriate question to ask? What's an inappropriate question to ask? So I think a big hurdle is just going to be getting people more familiar with it and more comfortable and more exposure to it, and providing them with more information, both about the disorder more broadly and as far as the experience that people have. And as far as potential avenues for doing that, so with my own research, it wasn't particularly on bipolar disorder, but what I found is that it was actually inspired by the fact that I have bipolar disorder. I found that actually using humor to disclose sensitive topics can be extremely effective because people don't view it as serious of a topic, which can be risky if it's something that reducing the perceived veracity of the topic could potentially make people not take it seriously at all. In this case, it's the opposite problem. People take it very seriously. So actually using humor to set people at ease can be a potential beneficial way to actually engage others. And also, if you're disclosing the information personally, to disclose it in a way also where you don't take as much of a hit to perceived competence or likability while you're actually talking about it.
Thank you. Thank you very much. So a number of questions, comments coming up in the Q&A perspective here. And one is just is focusing on the arts as having a role in prevention and resilience and in building in the brain field. And so as we engage, any numerous, individuals, how are we going to use creativity and the arts to really enhance our programs to build culture around this? And so, Julia, from the point of view of the, from the blues and policy at that level, do you see the arts as having a role in engaging people and figuring out how to bring more people into the mix, both from the perspective of providers, patients, and policymakers?
I think arts are just so powerful in that way. And we also know that so many artists struggle with mental illness, right? This is a pretty well-known fact. And we have some wonderful artists that are really well-known historically so I think, whatever you can do to, as a clinician, to engage folks and to get those messages out there. I think what Brad mentioned in terms of using humor, I think also in using art, how can we use art and show kind of the beautiful things that can be created, both in terms of therapeutic, but also in terms of telling people stories. Many people tell their story, Brad maybe kind of uses humor. Some people tell their story with art. I've seen some really incredible art expeditions and shows from people that have mental illness that were just some of the most beautiful things I've ever seen. So I think the more that you can tell the story and provide those services in a way that people respect them and can use them, I think the better.
And Marianne, do you think that art therapy should be something that we have a code for paying for, and how should we reward art therapists in the community?
Yeah, absolutely. I think that we really need to think about how we connect many aspects of a broader community to support people with mental health needs. And so, yes, I think art therapy is a really important part of the treatment. I also think we have to think about peers and, how we talked to, I think Norman, your talk, you said you didn't know about NAMI. We don't fund peers in the same way that we fund other services. So I think there's just a whole gamut of services we need to be thinking about. Those are really powerful supports to so many people, and they're just not well supported or well known.
Thank you. And welcome back, Paulie. The question was focused around the arts here, and how we would use art in management and treating bipolar. If you wanted to comment, if you had any comments on that.
Yeah, I'll just briefly say that in our trauma and grief clinic, we use evidence-based trauma-informed cognitive behavioral therapies, and oftentimes we're working with kids and adolescents to develop narratives. And we've learned that we need to be flexible. It doesn't have to be a written narrative. And so for a lot of the kids and adolescents we're working with, they are doing their trauma narratives from an artistic perspective. And that's been very powerful to see. So that's one of the ways we're incorporating that in psychotherapy.
Tremendous, terrific. So there are a number of comments that in the Q&A that are asking about, as I mentioned earlier, an example of some place, space, entity, country, state that is exemplary for providing mental health. There are a number of questions. For example, Norm, you mentioned Maryland. That your son was in Maryland, and there was a disconnect there with the health systems, and there's an institution there, Johns Hopkins, as one of the more preeminent institutions nationwide and worldwide. Why do we have systems that are so fragmented, and why is it so difficult to come up with an example of some place where mental health care is exemplary?
There are examples around the country, and you're providing some of them in Michigan, thank goodness. And we have Miami-Dade, and there are other places where they're doing some innovative things, but it's a crazy quilt system. And, there are advantages to a federal system and there are disadvantages. One of the things that my wife and Judge Leipman are doing is joining together to try and come up with a better standard that can be applied nationally. And at least in some of these areas, we need at least, I think, an interstate compact so that we don't get dramatic differences from one state to the next. But, let's face it, another part of the problem that we have here is the culture themselves that we see in states. So I mentioned Maryland in part because Maryland, Connecticut, they're two of the three states that have no assisted outpatient treatment and are ranked right at the bottom by the Treatment Advocacy Center on places where you can get adequate treatment if you have a serious mental illness. And it's because there are real legitimate concerns about civil liberties. We know that. We do not want to go back to a time of these hellholes that were the so-called asylums. But if we don't begin to recognize that people who are psychotic and cannot take care of themselves, that there's no freedom to freezing on the streets or being beaten to death as a homeless person, or basically getting into a set of conditions where your life is endangered or others. And we have to strike a better balance. And I think we need a national conversation. And then coming back to the arts, the arts make a huge difference in terms of changing culture. We saw that with same-sex marriage and relationships, with television shows, with movies. Julie mentioned that the number of celebrities who've come out and talked about their own illnesses or family members, and we have many of those, and they make a difference. I'm trying to do a little work with the NBA, where so many of the athletes, we have one here in Washington, a Washington Wizard star who has taken off for the first couple of months because of his own mental health challenges. That's a phenomenon. If we can get that out there and begin to have a better discussion, maybe we're going to see some of the changes in the law that will bring about a change in the culture.
Thank you. So from Brad, I want to ask you a question just regarding, with your background in economics. And as I understand, economists, and they're looking at larger trends, in societies and thinking through, where resources and where priorities are made. What I'm hearing here in the discussion is that as a society, we are challenged as a population, as a society, by the fact that our priorities are not as centered as they might otherwise be. And so I'm interested to know from the perspective of an economist is how we should be, starting to look at the data, where there's talk about a paradigm shift. And in order to really initiate and be part of a paradigm shift, we really need to understand the data. And Norm and others have been, talking about, where things are and what the status are. How should we approach the problem in an organized way, and how might an economist approach it?
So as far as one method to actually approach it is, so clearly we have an issue where it's coming down to people. There's not enough supply of psychiatrists and proper treatment and clinical psychologists and the whole support system. Also part of that is related to, I think also driven partially by demand. So as far as there was that issue as far as whether or not people can actually make enough money in that field and how they could actually make less. So part of, I think, fixing the demand will actually come down to getting people to reducing the stigma and getting people to actually realize, like from my own personal experience, I think one problem that people really face is that the attribution of how much this is volitional versus how much of it is actually the illness is unclear to people. And even as someone with the disorder, sometimes like I'll do things I won't necessarily, during my manic episode years ago, like I struggled with that, like how much of this was me, how much was it was the disorder. So I think improving communication, actually getting people to recognize that, look, it's completely okay to actually reach out and actually receive help. Will help actually increase the demand. And I think part of that will just come down to both for communicating to people with the disorder and then also to influence as far as potential funding for it. What we know from the behavioral economics research is that a lot of things just boil down to framing and just figuring out and actually running studies and figuring out, all right, so what's the best framing to get people to recognize this is an important issue and we need to actually tackle it.
Thank you. Amy, so this then in the context of framing, you and I have had a number of conversations as to how we would then frame the question. And that, so pick it up from there in terms of how are we going to frame it? And one of the things that I'm challenged with is that, okay, if we increase the demand, there's a supply for the demand that we need to address. So I'll leave it to you, Amy, to solve that problem.
Oh, sure, in a couple minutes, no problem. No, but I think in many respects, we've heard a lot of great ideas. I know with Dr. Gibson's work in trauma-focused care in the schools, you're starting early, and I think you're also involving the community. And in addition to Brad's comments about behavioral economics, there is a science behind behavior change in a context of organizational constraints where you can really empower frontline providers and consumers to be part of their care in a collaborative care fashion. And I think there's a lot of potential innovations that are happening, and it's not really a dichotomy anymore between public sector and private sector. I was just on the phone with someone talking about a new program or initiative called City Block, which is available in a few states. And the purpose of City Block is building a health system around essentially having a community build the health system and not the other way around. And so community partners are helping individuals get the care they need if they're on public Medicare, Medicaid, and so forth. It's basically building the system to really help them and providing collaborative care and providing care in a learning healthcare fashion where essentially every time someone is helped, that we learn from that situation and improve the system going forward. So those are just a couple of ideas we have to really think about how the system can be changed.
Thank you. And so the encouragement of in the economic model that Brad is pointing out, Julia, is that we need to have the reimbursement strategy for the providers in order to attract more individuals into the system. We need to have more providers. We need to be a little bit more flexible about whom we pay. And one of the challenges that we have now is that there's a rigidity to the pay structure and who can bill. We can bill. So RNs, for example, they're not allowed to bill for their services. So how are we going to start the balance of this supply and demand system going forward in the mental health realm?
I think a couple ways. So I agree there historically has been some rigidity in that. I think the first thing on the lower end of the spectrum, right, is that in terms of not everybody actually, not talking about serious mental illness, but not everybody actually needs to see a therapist or needs to see a psychiatrist. And right now, if you're struggling a little bit or you're not sure, there's not a lot of those lower level kind of coaching, peer support. So kind of bolstering those to reduce some of that burden, and then kind of freeing up the providers and the clinicians that really need to see those higher level, because that's one thing. We haven't done a good job at that. And two, I think trying to move towards more of a bundled payment model for a lot of things, so that there's flexibility in who can be seen. So there's not this rigidity of is it that providers and organizations have that flexibility to make sure that it's the right person that is connecting with that individual to provide the right care, because it makes it. I mean, the fee-for-service model is complex enough. If we can get to more of an outcomes-based bundled service model, I think it would enable us to do a lot more of that, to have a lot of different kinds of providers be able to treat our patients.
Thank you very much. And Marianne, this leads directly into your field, the outcomes-based strategies and that. And so pick it up from there. And how are we going to start programs or change the system, change the culture to be outcomes-based?
Yeah. And I also want to go back to an earlier question you asked, Melvin, about why the systems don't work together, because I think we have to understand that to get to outcomes-based collaborative care, right? Which is what we need. And I think we have to understand, this is so historical, right? We've treated mental health as totally separate from what we call physical health, even though they're both physical, right? We funded physical health in an entirely different way than we funded mental health. So let's look at Michigan, for example. We have a public mental health system that is funded through one line of funding that is really separate from how our hospitals and our physicians get funded for everything else. These are two completely separate systems. We have the proposals in Michigan right now to change that funding model, but those proposals don't do anything to change the care model. And it's the care model. What we need is collaboration, right? Between primary care physicians, between mental health practitioners, between peers and families. We need those together as a team to work differently. And that's why I'm excited about the community-based model that's been introduced that we're now embarking on in Michigan. Just started October 1st. We've been there in Washington County. We passed a millage. You know, Washington County is a county that is funding mental health more than many others. So we have more support to do this coordinated care at the clinical and family and community level. And that's where we need to focus, not at this level of, is it the health plans or is it the public system? These systems do not work together today.
Right. No, I mean, that's the challenge. And so now outcomes care. So how do we measure? This becomes a major question of outcomes, you know, and so Paulie, how are we going to measure, what outcomes should we be following? I mean, you have a very wide, range of outcomes that you are monitoring, ranging from PTSD to substance abuse and mood disorders and so on. How do we prioritize outcomes, and who should prioritize the outcome?
Yeah, that's a really great question. And, you know, I think a lot of times it depends on who you ask, which is sad, because I think what we're trying to say in this discussion, or one of the things we're trying to say in this discussion, is that we want to prioritize our humanity. We want to prioritize the rights of people to have a quality life, or, you know, to have the pursuit of happiness. And that's what what many of us here are working on. That's what we're trying to prioritize. And so I think in terms of, you know, outcomes, what we're talking about at the school system level, and schools have really awakened to this, you know, their outcomes were academic achievement. And it's not just me, it's a whole team of us that are doing this in the country, but we've had to help schools recognize that if a child comes to school and they're traumatized and they're not ready to learn, you can have all the great academic programs in the world, and they're not going to be able to learn that information. And so schools are recognizing, and this is even before COVID. I mean, now schools are obviously really focusing on social emotional functioning. So I think depending on the system that you're in, you have to get an understanding of what matters to them, and then help them to understand how mental health and mental illness is impacting what they care about, and how with collaboration and innovation, we can help to address what they care about, but we can also help to address what's interfering and getting in the way of people having a quality life.
Thank you for that response. And so, picking up on your point about innovation, that leads us, to what we should be thinking about in research. And so, I'm interested, Norm, from your talk. You know, you pointed out, you know, the challenges of, in bipolar research, the decrease in the funding going to bipolar research, 10% of the grants supporting bipolar research, and there's been a few comments in the chat and Q&A about the challenges for early career scientists getting into bipolar research because of the limited amount of energy, funds, and so on there. How should we prioritize, or how should we work to change policy in prioritizing bipolar research?
So I think I would love to see somebody come in and head up NIMH with help from somebody in the White House. And this is a general problem, I think, in science, and really begin to put aside a portion of the enormous amount in our budget that we put into research on out-of-the-box thinking and innovative programs. But also, when it comes to bipolar research, the study was not even about the small amount of money going to bipolar research per se. It was about the fact that most of the money that's going into it is not going to help people who struggle with the problem now. So we need to think about altering our research priorities, I believe. And that includes, looking at first, both how we can head off the possibility that somebody will have a psychotic break and come down with bipolar disorder or other serious mental illness. And we're seeing, of course, now a lot of focus on early intervention, including especially those who have trauma at an early age who are going to be more vulnerable. My guess is we're going to see more of this now because of COVID, because it's very likely that it's not just the depression or suicidal ideation or PTSD, but we're going to see an upsurge in serious mental illness and in schizophrenia and bipolar disorder because of the additional stress that's been brought there. We need to look at ways of seeing before those breaks occur if there's something we can do. And a lot of what you're doing to deal with the problems that people have now so that they can resume their lives in a better fashion. We're seeing some of this with medications. We're seeing some of it, I know, the breakthrough work that you've done on diet even. There are a lot of ways in which you can simply say, this isn't just about looking at things that might have payoffs in terms of understanding the brain for future generations. It's about directing the research so that people can be helped now.
Well, that's it. And picking up on that point, I just want to offer this to the rest of the panel members. You know, how do we help people now? So, Amy, pick it up from there.
Sure, I think there's actually an opportunity to change the culture and the way we fund research, and to change the culture around how the work that we do and the advocacy that we do can be valued. And I think what happens with a lot of researchers who are passionate about changing the mental health care system is that they put in studies that are very real world and are really focused on practical changes, like, you know, what Julia talked about in terms of payment models, or Dr. Gibson's work on trauma-focused care in schools. They go to study sections full of biomedical scientists who say, which is fine, I love biomedical scientists. Some of my best friends are biomedical scientists, but frankly, they're saying these are too messy, this is not appropriate, this is not basic science enough. And I think we need more of all of you to serve on these panels that review grants, and so that they can get funded, number one. And there's an opening because there's been a big push to really rectify the racism that happens in funding, where not enough Black scientists are being funded because they are addressing real world lived experiences issues in their communities. And there have been articles written in both the basic sciences and the health services and other areas saying fund more Black scientists. And in doing so, the peer review committees now have to basically be comprised of people who are going to have the expertise to review these real world type of projects. So I think it's changing. There's been more stuff coming out of NIH wanting to see real world work. And I think this is one area that needs to change. And I think we have this opportunity to make it change.
Thank you. Marianne, your points.
Yeah, I think we need to look at the mental health system more creatively than we have, and we have to fund it differently than we have. We have to recognize that we don't right now have enough psychiatrists, and we don't have enough psychologists, and that is a long pipeline. And if we're really going to help people, we have to think more innovatively about care teams and how we fund care teams across our states and across the country, because there simply are not going to be enough practitioners out there for everyone. You know, the points that have been made several times about the intersection between our justice system and our mental health system, and the work that Paulie and others are doing in our education system. We need to tie these systems together, right? We need that, and we need our police not to be the first responders when we have a mental health crisis. We need a mental health team to support those individuals, so it doesn't become the kind of tragic confrontations that we have seen. So we need to bring these systems together. I really do think the models in Florida, which is happening in Detroit, we've got great people who are really exporting those models and a lot of advocacy. We are seeing more money coming out of Lansing to support these systems. So I think we need advocacy. So my message to this group, we've got a lot of people on this group, and we need you to be advocates in Lansing and in Washington to get more funding and to focus on supporting a broad way to help in the mental health space.
Thank you. So one of the things that one has learned about at the global level is task shifting. And so Julia, at the level of providing reimbursement for things. This is sort of similar to a question I asked before, but who should we target, for task shifting? Should we be engaging peer, how can we get more peer support specialists, for example? Should we be repurposing or reassigning individuals in other entities to work in the mental health field and reimburse them for that?
Yeah, so I have been planting some psychiatrist seeds in my backyard. None of them have grown, so we have not getting any extra in my back garden this summer. Nothing has grown so far. So you're right, we don't have enough, and it's not realistic to think, like Marianne said, that pipeline is very long for those. And there are, I think, a lot of opportunities for us to engage. Again, kind of peers. And I think there is this other movement that I think Blue Cross is exploring, and I think lots of other health plans are, around coaching. It's this new kind of model. I think it makes all of our behavioral health folks a little bit nervous. Like, what if you see somebody and they're very sick, and what happens? But again, we're trying, to do our best within the constraints of what we have. And we can't just kind of keep doing the same thing and keep thinking the same thing is going to happen. So we are trying to kind of invest in supporting more behavioral health providers, paying people more appropriately. I know Marianne mentioned, the payments, trying to standardize that across the board. So if you see a psychiatrist, you see a primary care doctor, you get paid the same amount. Hopefully those incentives will happen, but it's not good. It's going to be a while until that kind of comes to fruition.
No, thank you. Now, Brad, from the point of view of someone with a sort of person with lived experience, speak to us about your priorities, or what would you like to see in an ideal world? Where should we put our efforts in research and developing systems?
So as far as like systems to develop, just thinking about one project that's currently actually you are working on. I think tools like the Priority app are amazing, because ones that can actually give us autonomy. Because I think one of the greatest fears is right now, like a guardrail that I personally have in place is that if my mood starts to falter, I have my family and they'll just tell me, hey, like you sound a little off. Like maybe you should actually take steps to actually fix that. What's terrifying is like, down the line, I won't have my parents. They won't always be able to do that. So actually having more of those tools like that to give us own personal autonomy, so that way we can improve our own self-care, would be fantastic.
Autonomy is great. Paulie, from your perspective, and I think you'll be the either penultimate or ultimate speaker here, how should we prioritize? How should we focus on helping people? And the emphasis in helping people now here, this is what Norm has challenged us to do, is that what can we do that's going to help people now?
Well, I think that we've talked about it, and it's really, seeing and recognizing the barriers that are getting in the way of helping people now, and recognizing that, having a serious mental illness is not just, a homogenous group. We've given some voice to, if you're a Black or brown person in this nation, now people are being advised, don't call the police when your loved one is having an episode, or is being psychotic, or, dysregulated, because unfortunately they're ending up dead. And so I think what we have to do, and I know that the people on the panel are committed to that, is we have to see and hear everyone's pain, and we have to think about ways that we can come together. And so we talked about how the criminal justice system, the mental health system, the public health system, there's opportunity here. There are these elements of a perfect storm. We're talking about how to root out anti-racism and all of these systems. And I think in doing so, we can kind of knock down walls, and we can bring more people in to help people understand, hey, I see what's happening to you. I hear you, and I care about that. Do you see and hear what's happening to me? And then how can we work together to try to make change at a higher level?
Thank you very much. And I think that that's just a very appropriate summary of what we're here tonight to do, and that is bringing people together. And thank you, Paulie, for summarizing that so eloquently. And so I want to just personally thank Norman for coming and joining us this evening. Even though we're on Zoom, we would have loved to have had you here in Ann Arbor and for personal engagement. This has been fantastic. I want to thank everyone on the panel for joining us this evening, and particularly Brad for coming such a long distance to join us, and everyone for your insights and comments at every level. It's just been absolutely fantastic. So thank you so much. And also, I want to thank our organizers for helping us. Amanda as Hudek has been just phenomenal at getting everything organized and keeping us on time and on track. And so I thank you for that, and Kat Bergman for helping with that as well. So thank you, everyone. It's been a wonderful evening. Thank you so much for joining us this evening. Good night.